These are my disclosures. I'm a consultant or a speaker for a variety of companies, and I'll try to point out anything that jumps out at us. Okay, so I got assigned a very interesting topic that I found out about on Wednesday, because I thought I was going to give the endoscopic talk 7 months ago, but they asked me to talk about percutaneous pedicle screws, cortical screws, facet screws, interspinous process plates, global warming, and starving children in Africa. But I just wanted to focus on those four, and you'll see I'm going to focus on even more. And the way I looked at this kind of assignment was to ask, okay, what do all these things have in common? I would say that, from my perspective, in some way or another, they satisfy a very simple set of criteria that makes them a minimally invasive strategy. So basically, to say that, you kind of have to have a philosophy of minimally invasive surgeries, and I want to just go quickly through this because I want to catch up. But the take-home message, at least from the perspective of posterior lumbar minimally invasive surgery, it's basically about preserving the integrity of the multifidus muscle, both in terms of pain and function, because there's a body of evidence, most of it indirect, that tells us that the multifidus muscle is important. And if you just sat there and put your hand on the multifidus muscle and just wiggled around, you'd realize that is a very powerful muscle. If you look at its micro-architectural design, it's uniquely designed. It's not like all the other back muscles. It is really strong, but moves very little. So this is one of our micro-architecture papers that came out a while ago. And I can ask anybody, even patients, I wonder what a very strong muscle that moves very little is designed to do. It's really a stabilizer. It's not a muscle for locomotion. It's a muscle to kind of keep things in a particular position. And the important thing is that it's like an Arnold Schwarzenegger. It's not like just a normal person. It's sticking out there all by itself, and you just can't help but notice it. So if you injure that muscle, not other muscles can't easily kind of take over. So if you agree with me in that philosophy that the multifidus muscle is important, the next question really is, how do we try to avoid injuring the multifidus muscle as much as possible when we need to do things to the spine for symptomatic reasons? Number one, I think most of us would agree, crushing a muscle, very bad, muy mal. And one good way to do that, besides having a tractor trailer run over your thigh muscle, is to put in these powerful self-retaining retractors and just crank that sucker and leave it there, which is basically what we do when we do a midline laminectomy and put in those powerful retractors. The other thing is muscles don't work very well when one end of its tendon attachment to the bone is not detached, is not attached. Guess what happens when we do a laminectomy and remove the spinous process? We detach one end of the multifidus muscle. So if you look at the multifidus anatomy, this is important because it has a single origin, one end. The origin is like one end. The insertion site, that's the distal end, has multiple attachments, right? So really, if you remove the lateral attachment or the origin from the lateral aspect of the superior articular process, it's probably not horrible because muscles from above are attaching to that site, and that muscle will attach to the lateral superior articular process at the level below, for example, right? But since it only has a single origin, when you remove the L3 spinous process or detach the tendon from it, there's no compensatory mechanism. So here's a very common patient, 4 or 5, degen spondy with stenosis, neurogenic claudication, back pain. I just wish I just took care of these patients because this is when they walk in the door, I'm just drooling. It's like, this is my favorite patient, my favorite surgery. Okay, so if you look at the anatomy of that and you do a midline approach and put in pedicle screws, lateral to medial, look where the L3 spinous process is. It's very low, and I think most of us appreciate that it is virtually impossible not to detach the L3 multifidus tendon attachment. Now, here's what's important about that. When you do a 4-5 fusion, you don't need a dynamic stabilizing muscle for 4-5, right? It's fused. You need it for 3-4 because that's the next level that's going to degenerate due to a variety of reasons. We call that adjacent segment degeneration. And just hypothetically speaking, I wonder if that muscle is important as one of the ways to protect ourselves from adjacent level degeneration. We don't have solid data yet, but I think anecdotally speaking, most people agree that if you do not detach the L3 tendon and you do some kind of fusion of 4-5, the L3-4 adjacent level degeneration rate is much lower. So I'll just ask you an anecdotal question. How many L4-5 standalone A-lifts that are fused have you had to operate on where you did a 3-4 fusion at a later date? I mean, I'd have to like just rack my brain to find that patient and remember it. I don't think I can even remember one. Same thing with an MIS T-lift or an A-lift with perc screws. But if you said, how about an open laminectomy and posterolateral fusion? That was my practice at UCSD. We called that the blue plate special number 1. They came in all day long. So when this data comes out, I think we'll see that you want to try to avoid, for example, injuring the L3 tendon attachment when you do an L4-5 fusion, right? So it begs the question, how are the different ways that we can do it? When you put in percutaneous pedicle screws for fixation, you're completely avoiding the multifidus muscle, not completely, but you're coming in lateral to medial. When you put in cortical screws, because you have a medial to lateral trajectory, that incision can be very small and you can preserve probably half of the tendon attachment. And then facet screws are practically crisscrossing. That will also protect the L3 spinous process, and so will an interspinous process plate, right? So perc screws, cortical screws, facet screws, interspinous plate fixation. If you're doing a fusion and you say, I'm doing a fusion of 4-5, and my main minimum invasive goal is to avoid injuring the L3-4 level so that it doesn't degenerate in the future, this adheres to the concept of MIS. They're all MIS, which is fantastic. Now, I think you already have the sense that 15 years ago, it's like we had one MIS surgery. Today, we have option after option after option. So I was tempted to like go through the literature and just like basically compare and contrast all those techniques. But anybody can do that. You probably want somebody that has done all those things and has lots of experience talking to you about, you know, what the real details are. So it begs the question, I'm sure you're asking, like, I wonder how many cortical screws he's done. Only several. So my thinking is that if somebody's asking me for advice, if I haven't done something 50 to 100 times, I really do not understand the performance profile of something, right? So the first question I ask somebody if they're kind of giving me advice, like, oh, really, how many cases have you done? If they don't just say like 50, 100, hundreds, I just tell them, okay, well, let me know what happens. Because you can't, in this day and age, you need to do that many cases to really understand all the ins and outs of something, because 25% success rate is not good enough. I mean, technically speaking, you need to be in the 90s, technically speaking. How many interspinous process plates have I put on for one reason or another? Several. How many facet screws have I put in a patient? 0. But here's the thing. Back in 2006, I did a cadaveric study and looked at that. So it's sort of like that commercial, like somebody's got into a car accident, and somebody runs up and they're helping him, and somebody says, wow, are you an orthopedic surgeon? It's like, no, but I slept in a Holiday Inn Express. So when somebody asks me about facet screws, I just like, well, no, I did I slept at Holiday Inn Express, but I really don't have enough cases. What about perc screws? I've put in a whole lot of perc screws. So instead of going down and trying to compare and contrast perc screws, interspinous process plates, facet, let me kind of go through what I think is important about pedicle screws, because here's what I noticed. There are tons of awesome technologies. The 4 fixation systems that I talked about, I think in one way or another, each of them has its pros and cons. O-lift, L-lift, MIS T-lift, etc. But what I noticed is that it's like walking into a car dealership and seeing a Bugatti, a Ferrari, a Lamborghini, and feeling like, okay, I love those cars, but I'm so nervous to drive them. I don't think I know how to drive a car like that. I'll take the Honda Accord. It should not be like that. I mean, perc screws have been around forever. MIS T-lift have been around forever. X-lift has been around forever. But I can just tell you, if we just took every spine surgeon in this country and asked them how many surgeons are actually real, like people that treat patients with those technologies, I'm shocked at how low it is. So the technology is just exploding. The huge bottleneck is really a very basic question. Why isn't everybody doing it like this? So I'll give you an example of one of the things that I think is the reason, because I spent a lot of time trying to understand this problem, because we train a lot of surgeons. And after a while, I was just like, I'm sick and tired of training this surgeon again. He's not going to ever do it. We have to ask ourselves why. So here's an example. See this kind of diagram? We see this all the time, right? You want to have a perfect AP. You want the end plate to be flat. You want to span from lateral to medial, right? But that is so not enough. You have to take it one step further to really pass this kind of threshold or activation energy. And I kind of gleaned this from the Skin to Skin program, and training surgeons really paying attention to how they're doing, and most importantly, finding out if they actually went back home and did a case. It's almost like the results of your surgeries. It's once you start following the outcomes, you start realizing something's not right here. So here's number one. That one slide from before, that's way too generic. That's just sort of like, that's a Bugatti, but no, you can't drive it. You can look at it. That's what that's like. If you want to drive it, you got to go, okay, hold on for a second. I got to tell you a few other things. So here's number one. When it comes to percutaneous pedicle screws, the first thing I noticed is each pedicle has a personality. Some are skinny, some are fat, some are hard, and some are soft. They all differ. And in a single patient, they differ. So if you just go through and say, okay, the perfect screw from S1 to L1, totally different issues. That's S1. That's L5. So you can see at the starting point of L5 is at the junction between the TP and the supraarticular process. It's in a trough. But as you go higher up, guess where the starting point is? It's starting to be on the hill. Okay, before I forget, can somebody give me an idea of the time? I totally forgot to check. That should be done by 10, right? 9:57. Okay. I need a timer. Okay, so look where the starting point of L3 is. I mean, you're like sliding down that thing. And L2 is even worse, and L1 is even worse. So here's what we're faced with. When it comes down to the nitty-gritty and you got your own patient that you have to follow for the rest of your life, what does it boil down to? You're in the OR and you've got the image on the left. But really what you are looking at is a two-dimensional representation of a three-dimensional structure. Because if a pedicle was just straight in like this, that circle of the pedicle would be a true representation of the anatomy, right? But the pedicle is angulated, right? And it's kind of like a funnel. But you're looking at a circle on a 2D view. So how confident are you that that view is enough to know exactly where you are? You cannot just rely on that. Is that the timer right there, that big, huge green thing? See, you put it right in front of my face where I couldn't see it. I've got oodles of time, 4 minutes. I don't even know what I'm going to do for that long. So here's the thing that I have to tell people that is so mundane and simple, yet if I don't tell them this, they will screw something up. I call it walking the dog, but really it's called walking the TP. So you've got a two-dimensional representation of a three-dimensional structure. What else can we do to kind of like sort this problem out? It's really simple. I always tell them to start on the TP. I have to beg them. I'm like, start on the TP. It's like, no, don't go for the target site. Start on the TP. Because if you do this, it'll give you one added dimension of anatomic understanding. So you've got the 2D fluoroscopic view. Now you've got a kind of like a palpatory view. And when you hit the TP, first of all, you can kind of like probe it around. And you can tell it's the TP. You fall off the top, off the bottom. And it has a very distinct feeling. And so I just simply start on the TP and I just walk medially, walking the dog, right? When I am walking medially and it starts rising up on the supraarticular process, I know where I am because I have a kind of a general idea on the fluoro that I'm in the right ballpark. And with that little maneuver, I'm like, I know exactly where I am. I am just riding up the supraarticular process. And at 5-1, I don't want to be there. At 5, I don't want to be rising up on the supraarticular process. I want to be right at that crotch. So then I just back it up. Now, this seems really boring, but if I don't like just beg the visiting surgeon to do this in the cadaver lab, they will usually screw this up. Now, as I'm hitting this in, there's one other thing. If it's in the pedicle, it will feel a certain way. Like that joke about the dog. That tastes like dog poop, that smells like dog poop, it feels like dog poop. Thank God I didn't step in it. Same thing. It has to look right, it has to feel right, and it has to behave right. So when you have a gem sheeting needle in about like that, it should have a very specific feel, and you can take the top and you can flick it, and it will twang. Twang. If it doesn't twang like that, you're like, why isn't it twanging? Call that the twang sign. You have to have it needs a better name. Something that's really memorable, but that's as close as I got. Now, if you're just looking at the image on the left, because that's basically what you have, right? You're going from lateral to medial, you'd be surprised how easy it is to get into the facet joint. Because it's kind of like pretty well fixed. You're moving lateral to medial, and unless you get a lateral x-ray or an oblique while you're doing it, which we usually don't, we're just usually like, okay, I'm going to hit it a little bit more, you're likely to kind of start skating down this facet joint, heading toward the canal. It's very obvious when you're in there, because about halfway to 3/4 of the way in, it will stop like a rock, because the supraarticular process is very sclerotic. I call that the facet hard stop sign. So if they're hitting it in, they're like, it just stops, and on the AP X-ray, it's not past the medial border. I'm like, whoa, I think you're in the facet joint, and I look really smart, because they'll get an oblique view or a lateral. I'm like, how'd you know that, Choll? I'm like, I just do, okay? But it's that simple. It will stop rock hard. And when it does that, don't keep hitting it. Figure out where you are. And then I put in all the guide wires first, but that's not the important thing. The important thing is, do not even think about putting in a tap or a screw until you're absolutely positive the guide wire is perfect or near or satisfactory. Because if the guide wire is off a little bit, you can fix this problem. You put the screw in and it's a little low. You're not going to be able to put in a good pedicle screw into that pedicle anymore, because now you already have a huge hole. You put in another hole right next to it, guess what happens? It's one large oval hole now, and it's usually not very good fixation. So I look at it in multiple views, even though it's hard. AP, oblique, where I can see the facet joint line, lateral at every single level. If I'm lucky, I can get it all in one view, but if not, you're just wagging back and forth. That 4 minutes went by like really fast, because I have now exactly 15 seconds, so I'm going to be over about a minute. Sorry, Jeff. Okay, so that's that. I'm going to run through this because this is kind of a concept thing. What's another thought? This is more general. When it comes to just percutaneous pedicle screws, we have a bunch of different options to get this better. We have navigation, we have better needles, we have multitude of improvements. Those are all awesome things. What's limiting is how to assess the technology quickly. How to take something and go, that sucks, that's awesome, without doing 100 cases. You know that Morgenstern case 72? Who in the right mind would do 72 surgeries half-ass until they can get good? If you're in practice and taking care of patients, if you're a resident or an intern, you can screw up all 5 years and then you're still fine. It's like a daddy's credit card. When it's your own patient, you cannot screw up even once, at least mentally. There's no such patient that you look at that's your patient and go, if I screw this up on this patient, it won't matter. There's no such patient that exists like that. So we need a methodology and an effort to take new technologies and very quickly assess them. So I'll give you an example, perc screws. You know how, if you look at the literature, they're like, we've put in 1,500 screws and discovered that the perforation rate is 2% or whatever. Somebody comes out and says, I've got a better way to put it in. Okay, let's do another 1,000 perc screws. Well, you don't want to do that. So one of the things that I did is just ask myself, how can I assess new improvements in pedicle screw insertion strategies without doing 1,000 cases? So I said, if I try to put in a perc screw perfect every single time, that's a 10 out of 10. If I do it any less than that, it's less. So I'm going to compare the way I do it with a new way. So navigation is an example. And you just have to come up with a scoring strategy. And if you look at it, you can ask yourself, okay, navigation versus floral, what's the issue? And is it better? For me, the accuracy is better, and the clinical insertion time may be slightly higher. So I did that in 10 cases, because back in the day, I did a lot of multi-levels, which I still do, but UCSD, that was my practice. Around 10 patients, I figured out, okay, this works pretty well, and I think it's as good, if not better, than when I use fluoro in terms of putting in the perfect screw. I don't want to wait until I screw something up and and lacerate a nerve to find out that navigation sucks. Same thing with insertion time. Now, the other thing is when new technology comes out, if I were the one that's kind of driving new technology development, I would want other people to think it's totally cool too and have them adopt it, right? It's no good for me to be the only one to do it. So you have to figure out issues related to the learning curve. So I took a fellow and we did a Cadaver lab and we looked at insertion time, for example. And it's the same for C-arm and O-arm. But here's the thing. If you look at, okay, what's the accuracy related to time when you use the C-arm? As you get faster and faster and faster, you don't have as many perfect screws. Whereas in navigation, you still put in the perfect screws. You're just getting faster, but still having the same perfect screw trajectory. That's just an example of, that's not the point of that set of slides. The point is when something like OLIF comes out, you should immediately start thinking of a strategy to look at what's better and what's worse. And we can't wait for hundreds of cases. We have to figure out a way to do that. And because I'm completely out of time, and this thing is totally red, I would say that when it comes to perc screws, practice is important, and learning the subtle tips and tricks. It's not enough just to get that one first image. You need to find like a life coach, an MIS coach that will teach you all these tips and tricks, and that person should have done hundreds of them. And I think I already talked about the whole better learning curve assessment and more efficient assessment of new technologies. Thank you, and sorry for running over.